Continuing on with our discussion about antacid drugs and drugs for peptic ulcers, we have some adverse reactions that are unique to each one of the drug categories I talked about. With antacids, usually just some mild GI problems. If somebody's just popping antacids one after the other, they can lead to the symptoms seen here: loss of appetite, belching, irritation, constipation, eventually bowel obstruction. So it's recommended that if somebody's got gastric problems so bad that they're just taking a huge amount of Tums and Rolaids, they probably should go see their doctor and switch to something else. But one of the more dangerous aspects of using a lot of antacids is that they are all mineral derived. So you've got calcium, magnesium, aluminum, sodium. And so if you've got a patient who's got cardiac problems, if you've got a patient who's got kidney problems, these drugs might not be conducive to their health. And so it's important that they not just take antacids as much as they want without talking to their doctor. The H2 receptor antagonists can cause mild side effects: dizziness, headache, make them sleepy, usually very mild. But in adverse cases, you can get diarrhea, and then severe cases, hematologic changes and muscle pain. They're generally considered pretty safe, although they can interfere with that cytochrome P450 system in the liver and affect other drugs. And I believe I've got a slide on that coming up. The proton pump inhibitors, side effects can be headache, diarrhea, abdominal pain, and nausea, just what you need. And then adverse effects, very rare. It can cause a rash as well as vomiting and dizziness. But generally speaking, as far as side effects go, these drugs aren't too awful. Nursing implications and patient teaching. Of course, each of these drugs in the table has their list of nursing implications, and as well as in the text, those sections of patient and family teaching. As we're doing our nursing process, of course, you want to do an assessment of the patient, when all this stuff started, what aggravates it, what might help, and look at all the interaction possibilities with these meds. For diagnosis, mostly it's going to be education, as far as telling them to reduce their smoking and alcohol intake. Smoking increases stomach acid production. Alcohol intake increases stomach acid production. Both of these can make an already bad situation worse. Stress also can exacerbate acid overproduction. You want to tell your patient to, as they take these medications, increase fluid intake. Talk about the forms and routes of administration and how to take as directed. And it's recommended that they take the H2 receptor blockers like Pepcid at night, because if you remember, we produce the most acid in the evening, usually, 9, 10, 11 p.m. and so on. And it can be really hard to sleep when your esophagus is backing up on you. You want to see for evaluation what gives relief of this GI distress. What makes it worse, what makes it better. So be sure and look for all the family and patient and family teaching, administration times, specificity of drugs, what it works for, what they don't work for, adverse reactions, how to store the drugs, which you guys, you're going to be experts in this, of course. Any kind of medical follow-up, which is especially important if the patient has ongoing ulcers, and then those drug interactions that we've already talked about. For drug interactions, antacids produce or prevent absorption of a lot of drugs. You have to really separate taking antacids from other drugs. So usually an hour before or 2 hours after. Some antibiotics like tetracycline, if you've got antacids in your stomach, they'll just totally prevent that absorption, which defeats the purpose. In the presence of antacids, enteric coatings are going to dissolve more quickly, because remember, they're supposed to hold on through acid, and then not dissolve until they get into the more alkaline environment of the GI tract. And if you're making the stomach more alkaline by neutralizing acid, things are going to break down in the stomach, and then the already fragile stomach lining might be exposed to the medication. H2 receptor antagonists can interfere with the metabolism in the liver, particularly cimetidine, which I believe is Tagamet. If you take that at the same time as you take your other drugs, it can totally interfere with how your liver metabolizes. So it's recommended take your proton pump inhibitors and H2 receptor antagonists at night before you go to bed. Keep them separate from the other drugs that you take earlier in the day. Dicumarol, which is an anticoagulant that is very similar to, it's in the coumarin family, kind of related to Coumadin. It's absorbed 50% faster when taken with antacid. So that's going to increase the effects. If it gets in the bloodstream faster, it's going to make bleeding time longer. It can increase the risk of a person getting some kind of a dangerous bleed. When it comes to the proton pump inhibitors, there's a time factor. Remember, we're only using these drugs, or only supposed to be using these drugs when other drugs have failed. But it can be 6 to 8 weeks before you have a full effect from the proton pump inhibitor, where it knocks out enough of those little proton pumps that you're not making as much stomach acid. So our patients have to be told that they're not going to get immediate relief. It can take up to 2 months, which can be frustrating. Let's talk a minute about a bacteria that has been linked to many ulcers throughout the years. This drug is called Helicobacter pylori, or H. pylori. It's a bacterium, and it can, it's a normal flora in a lot of adults, not every adult, but many adults. But it can cause irritation of the GI tract and was found to be associated with 3/4 or 75% of gastric ulcers and like 9 out of 10 duodenal ulcers. Some doctors started working on this hypothesis back in the 1980s. These doctors were Doctors Barry Marshall and Robin Warren, and they studied H. pylori. And Dr. Marshall even gave himself H. pylori gastritis. He did not have the H. pylori as a natural bacteria, but he swallowed some and gave himself gastritis from H. pylori, and then turned around and cured it. And so he got the Nobel Peace, well, both of these doctors shared a Nobel Prize in medicine for discovering the part that H. pylori played in causing problems and ulcers that were not healing. In page 251 in our textbook, it talks about H. pylori and things that you can do to treat H. pylori. First of all, you have to give antibiotics to treat the bacteria. Usually a tetracycline or a similar drug will kill that bacteria, but then you need GI drugs to treat the ulcer that came about because of that H. pylori. Ranitidine is often used for stomach ulcers, whereas the proton pump inhibitors are very effective for duodenal ulcers, particularly which drug, folks? Yes, you're right, Protonix. Very good. All right, we're going to stop here. That's it for the antacid lecture. I do want to say that proton pump inhibitors don't start working for a couple of weeks, and it really is recommended that they not be taken permanently because of the damage they can cause to those proton pumps. However, it is not uncommon to see people who have been on Protonix and other proton pump inhibitors for a long time. You will see that, even though it's not really recommended. So that's kind of up to the healthcare provider, and nobody that I can see seems to be worrying about that. But anyway, we'll leave this section here, and when I come back, we're going to talk about constipation.